All right, so I have the pleasure of introducing our speaker. Dr. Katrina Nichols is graduating UK Addiction Medicine Fellow. She previously worked at Bluegrass Care Navigators as a hospice and palliative medicine physician. She continues to work with Bluegrass Care Navigators as the medical director of the Healing Transitions Program through the UK Healing Community Study. In the fall, she will join UK in the palliative care and addiction medicine. So welcome back, Dr. Nichols.
Hi, thanks for having me today. Nice to see some familiar faces and my team members as well. So we'll just dive in. Next slide. So practice gaps is that, healthcare workers, we all have distinct training backgrounds and different roles in patient care. And not only as workers, but as far as systems in medical, mental, and substance use healthcare systems and services, these systems often operate independently from each other. And so to fill that gap, care navigation is a way of supporting person-centered care. Next slide. So hopefully by the end of next week, participants will be able to list the levels and settings of medical care, of mental health care, and of substance use care, and being able to identify various healthcare workers and their roles in patient care. And then hopefully next week we can have a really good discussion about describing opportunities and challenges in care navigation for people with substance use disorders and co-occurring medical and mental health conditions. Next slide. So we'll start with substance use because that's the thing everybody's an expert in who's participating. And so we'll just recap on the ASAM levels of care. And I know Dr. Murphy already gave a KY open on this, but just review. That there are basically 5 levels of care. The first is a 0.5, which is prevention and early intervention. And so just to screen, well, we've talked about it before, screening and seeing if there's any unhealthy drug or alcohol use, providing that education so it doesn't escalate or cause harm. And then when somebody has a substance use disorder as an illness, level 1 is outpatient services. And level 2 being more intensive outpatient services or partial hospitalization, where you have at least 9 hours of focused counseling on drug use, psycho education, relapse prevention, and other psychosocial and community supports for that. And then into level 3 about residential and inpatient residential programs. And then the breakdown of that of clinically managed versus medically managed withdrawal services and medication management. And then we have level 4 intensive inpatient services in like an inpatient dedicated psychiatric substance user medical hospital. And then that is pretty much the same for adolescents as well. Next slide. And so where do most people with substance use disorders get their treatment? So remembering that a large group of people, especially for you with Voices of Hope, know that many people aren't even directly connected in the medical system. It's more self-help groups and in the community and people living shared experiences helping each other. And then about an equal amount of people in outpatient treatment, and then also outpatient mental health treatment who are also concurrently receiving treatment for substance use. And then inpatient, the ASAM 3.0 levels of care. And then in their own private doctor's office, most just a clinic-based integrated into medical care. They're also receiving treatment for substance use. And then in a hospital setting, emergency room and jail being the least common. Next slide. So thinking about the barriers to substance use treatment, which we've been thinking about this whole study, is limited availability of addiction treatment professionals, clinics, and facilities. There's not enough trained, certified professionals to meet the need. And then also thinking of, when we talk about limited availability, also that there's geographic availability. So even if we do have in a certain state like Kentucky many treatment professionals, they're not distributed equally where the need is. And those of you working in rural areas really appreciate that. There's also insurance policy limitations as far as like numbers of days in a certain level of care, and as far as like covering medications, treatment facility restrictions to medications, the ASAM levels of care 3.0, not all of them offer all medications for addiction treatment, for example. Lack of public education about the options of substance use treatment. Of course, stigma of our entire healthcare system, and this is just going to be the overall theme, why we need so much navigation and advocacy. And then also from the patients themselves, we know that many people in the survey of people of drug and alcohol use who would meet criteria for substance use disorder do not believe they need treatment for that. So lack of patient insight into the disease. Next slide. So this graphic shows that 97% of people who with substance use disorder did not feel they needed treatment. But then looking at that tiny sliver of the numbers of people who felt they needed treatment and made an effort to get treatment, but did not get that's 200,000 people in that survey. So there's a significant number of people there that if they're even wanting treatment that we could help with, and they're not getting that. Next slide. And then just remembering that for people who don't feel they need treatment, depending on how severe the disease is, that someone could file a petition. People are familiar with Casey's law. That's also sometimes been used as a verb of I've been Casey's laws, and I've been Casey's lawed and forced into treatment. But somebody can file a petition with the circuit court clerk for a person with substance use treatment and that person's not seeking treatment. And the tips to make sure that this goes through is setting up and making sure that you have appointments so that you have evaluations by 2 qualified health professionals, and one must be a physician. And so that when you have the court date is set within 14 days of the petition, but you need to return all those evaluations. And the petitioner bears the responsibility and the right to choose the treatment facility that they want that person to receive treatment. And then depending on the court, when they review the case, they can order treatment from anywhere from 60 days to a 360-day forced treatment, usually in a residential type program. Next slide. So that was just a quick overview of substance use treatment, and you guys are all experts in that and could talk more about that together. Moving on to mental health, and then next slide, thanks. So the levels of care sound awfully familiar. 12-step programs, which would be like prevention and would also be like self-help groups, and routine outpatient care, and intensive outpatient partial hospitalization, so very similar to substance use treatment. And then talking about residential or custodial living, which is more like group homes where people might live lifelong to have assistance with some activities of daily living and higher functioning. And then for inpatient acute, there's acute psychiatric hospitals. And then there's the forensic psychiatric hospitals for people with criminal or in the criminal legal system. And then there's inpatient residential, which, as we'll discuss when we explore the history of mental health here in a few slides, when we talk about nursing facilities and intermediate care facilities. So a bit different from substance use treatment in that these can be much longer term and could also offer custodial care lifelong. Next slide. Talking about inpatient psychiatric care, this I got from a treatment advocacy center when it was looking at the needs of people and how many psychiatric beds we have in Kentucky. And you can see here that they're basically the statistics are just saying we don't have enough beds for the number of people with severe mental illness. And so what happens is what they call criminal diversion. A lot of people aren't getting psychiatric care and are kind of being diverted into the criminal legal system. and then mental health court involvement. So this is just some statistics from that slide, just saying there's not many beds, and we have, I think on there, gained a few beds, but not enough for what we need. Next slide. So to gain an understanding of how the mental health system works in Kentucky, and we're talking about psychiatric beds, at least as far as funded hospitals, that the way Kentucky works is that we have hospitals that are geographic on these, is it 1, 2, 3, 4, 5, I'm probably miscounting, regions of Kentucky, and there'll be a dedicated psychiatric hospital that will take people from those districts. And so people could have very different needs, but if you live in those counties, you get filtered to them. So there are some local private psychiatric hospitals that can do some crisis stabilization, but then if they need longer treatment, then they'll move them to what we call like the state hospitals. Next slide. And so and then talking about people with serious mental illness and intellectual developmental disabilities. There is a program for people to try to keep them in the community and out of the hospitals. It's called assertive community treatment. And it's a team of professionals who have, it's an interdisciplinary team. So training in social work, rehabilitation, nursing, and psychiatry to really try to help keep people in the community and out of a facility or out of a psychiatric hospital. And it also provides case management as well as employment and housing assistance. And they also can provide substance use services. And it operates 24 hours a day and 365 days out of the year. The thing to note about that with assertive community treatment, however, there is no current funding to support that. And so community mental health centers are trying to provide that, but there's not funding allocated to that. And so sounds like a great service, but it may not be as easily accessible because of lack of funds for full staffing to operate it. And then we talked about psychiatric hospital. Tim's law is kind of familiar, like akin to Casey's law for mental illness, and we'll talk about that next. One note about the Michelle P. waiver is for services to support people in the community. They provide behavioral support, day training, help with adapting things within the home so that a person can live in the community, and they provide personal care and respite. So these are things that are available for people with serious mental illness and developmental disabilities. And this is a public health need because, as we know, for people with serious mental illness, that the life expectancy is about 15 to 20 years shorter for people with schizophrenia, and about 10 to 15 years shorter for people living with bipolar disorder. So really needing that support. And overall, what that for people with intellectual developmental disabilities, as far as life expectancy, is around 60 to 63 years of age based on US Medicaid data. So these people are younger, not living as long and really needing support. Next slide. And so Tim's law, like I said, is akin to Casey's law for people with mental illness. And so it would start with a petition, and it could be a petition just in an emergency room. If they felt that somebody was a threat of harm to themselves or other people, that you could do what we call a 72-hour hold. And then they can push through a petition to the Kentucky District Court that states all those things, that they have to present a threat of danger to themselves or to others. They must be suffering from a severe mental, emotional, or physical harm, or mental illness, and have impaired judgment and reasoning to recognize reality, and have substantially diminished ability to make informed decisions, as well as the person must have what we call, if I'm going to say this right, anosognia. So basically, the lack of insight into one's own illness. And this was passed in 2017. After a gentleman, Tim Morton, was living with schizophrenia, was not treated, and family saw that they were not able to save his life, and advocated for this law. But since the passage of 2017, it was only used once up until 2020, and mainly because of that last part where it said a person must have also been hospitalized involuntarily. Originally, it was twice in the last year, but they were seeing that they were missing a lot of people. And so they've actually adjusted that in 2020, that they passed to update the criteria for involuntary hospitalizations within the past 2 years. And so more people were able to access this petition for their loved ones. Next slide. So talking about barriers to the mental health care, there is limited availability of a lot of these psychiatric medications and injectables, limited affordability of those and insurance coverage, and not having enough trained mental health professionals to meet the need. And again, we could talk about geographic variability as well there. And then also some policy limitations as far as the levels of care. Medicare does have a lifetime hospitalization days limit for coverage. And then there are some Medicaid inpatient days limits for people who are under the age of 64. And then the lack of public education about mental health treatment options. And then, of course, stigma. Next slide. Now, this is very, very busy. When I was preparing for this presentation, I kind of went down a big rabbit hole with this one, but it was very interesting to me to try to understand where we are today and where we came through history and why things seem so disjointed. So just thinking through the United States and in the colonial times, when we think about medical treatment or mental health treatment. So in the beginning, it was all about infectious disease, coming over, and this is before the days of antibiotics and outbreaks. And the first hospital in the United States was established in 1750. And soon after that, also there was an emergence of a need for mental health they would call them lunatic asylums, that they would need to send people who seemed to be harm to themselves and to those surrounding them. And in 1773, the first asylum was established in Virginia. And interestingly, Kentucky actually was the second place where we had an asylum in the United States, right here in central Kentucky. And those conditions were very challenging. We know it from movies where we've seen people restrained and in locked rooms, and it seems very inhumane. It took a while, but around 1840, there was a movement started by Dorothea Dix to really expand and improve the conditions in psychiatric hospitals. And then, these were just places where they basically would just confine people with mental illness. And then actually, it wasn't, a few years later, 1944, the lunatic asylum, which is the name of it, which was actually here in Kentucky, which is now known as Eastern State Hospital, only then got its first medical superintendent, so a physician actually on staff to oversee care. And then, moving forward into Civil War and a lot of medical care for injuries. And then it started becoming, okay, how do we get this service? So this is where fee-for-service started to be born in the United States. And then getting a larger healthcare system with the Army and establishing a hospital corps because of the need for soldiers. And then around this same time, as we know, at the end of 1800 or so, when it comes to drug use, is when we started having criminalization and racist ideas about certain drugs, and then a decision that suddenly these substances that were out needed to be criminalized. As opposed to just something that someone was using. So we know cocaine was associated in the South with quote unquote Negroes in the South, and we must get rid of this harm to our nation. And opioids being brought over by China, and then the marijuana menace craze and the marketing around that, saying that this is very dangerous and invading the United States. So this was all happening. And then around the early 1900s, there's some progress being made with promoting childhood intervention and treatment in mental health, and advances for mental health and lunatic asylum being renamed Eastern State Hospital, which was just a better name for that overall. And then the idea for the medical care for this fee-for-service model, unions and private insurance really advocating for their workers so that they could have proper medical care. So all those things are moving forward positively. Now that we have the 1914 Harrison Narcotic Act, at least when it comes to drug use, of that not moving forward at all, that just being more criminal, again, not yet recognized as medical condition. And then we move forward in World War I, World War II, and we start seeing the divergence, the split of the thought of people using drugs and into the morphine clinics for soldiers coming back being viewed very negatively. And then the emergence of even thinking about alcohol as possibly a condition or disease, and we start seeing the birth of AA. And then with recognition that there were people being marginalized who are retired and elderly, and that's where Social Security started emerging. And so there were some gains in medical treatment overall that we're hearing, and a payer source for that, and recognizing marginalized groups, some gains in mental health, a recognition of that, and just only very early for drug and alcohol use. And then a big leap forward for mental health care with emergence of psychopharmacology and tranquilizers coming out and other ways to manage medically to decrease use of restraints, and thinking about people coming back out in the community. And so we see that in the second half of the century, especially under Kennedy, with the Community Mental Health Centers Act of getting people out of the Eastern State hospitals of the US and back out in the community, and really putting a lot of funding into that. And then also laying the groundwork for medical care with Medicare and Medicaid. And then in pink, where we start talking about drug use and alcohol use, a lot of legislation passed to just think about research for this, think about this as a disease, realizing that there could be some treatment, but it's just figuring out what that is and supporting that. And then, moving forward, we're used to what we find, the Medicare, Medicaid, more consolidation of advocacy groups. And then by late 1980s, Medicare adding outpatient mental health benefits and getting us closer to what it looks like today. So I know it's very busy and going through all of that, but it was very interesting for me to see the history there, just to see how much there was, at least when it comes to drug and alcohol use, because of the recognition so late of it being a medical condition, that it was kind of late to being inserted into our system, and that's why it's siloed. Next slide. And trying to correct that going forward to more present day, recognizing that, okay, we have more marginalized groups again. And so with the American Disabilities Act, so it's not specific to someone being retired or unemployed, making sure that they have access to accommodations, transportation, employment, and state and local services. And then the Mental Health Parity Act, which has been discussed since the 1990s and passed in 2008, to bring more equity to health insurance coverage of both mental health and medical care. And then, I put in the other things like data and care and support, which are more like just increasing access to medication for treatment of addiction. The bad part of this is we put in all this money into all these advances in research, and in some way, someone's going to try to cut the cost. I don't know that that's exactly what happened, but that's kind of how I interpret when I'm looking through the history is, Social Security Administration, that was what, 1965, to try to provide financial, just financial support to people. But in 1996, interestingly, they terminated patients for Social Security, and we'll talk about what Social Security is at the end, but for people with substance use disorders. So if you could answer that drugs or alcohol are causing or worsening the condition, and that the condition would improve if you stopped, then you did not have your Social Security payments anymore. And that's been going on since 1996. Next slide. And then I alluded to this earlier, but also talking about this concept of trans-institutionalization. We used to have state psychiatric hospitals or asylums, and that function, separately from the criminal legal system. But when we don't have enough beds, as we talked about, people filter somewhere. So they either have medical complexities and they end up in nursing homes, medical nursing homes, or they end up being diverted into in the criminal system. Because of some of the behaviors and choices made there due to mental illness. And this isn't any better because we have underfunding of community mental health programs, no funding for assertive community programs. So people do end up in jails, and you guys know this much better than I do and see it every day. There's also underfunding for housing support that leads to people to continue living in the criminal world to try to make it day by day. And then what we're trying to change is just incarceration for possessing and using drugs instead of getting treatment. Next slide. And moving on to medical care. Next slide. So I'll do the same thing. The levels of care for medical care is kind of similar. So first, we always have prevention. So it's community awareness campaigns about chronic health conditions. And then outpatient treatment would be like primary care. And so that could be community clinics or urgent care, or what people call like, your family doctor. But then when you need more specific care, as opposed to having more teams, kind of like when we think about partial hospitalization or, intensive outpatient treatment where you have more counseling, case management, and that kind of support. In medical care, we now have specialists. So you then go to like specialty clinics for a specific condition of professionals who know a little bit more about your condition or organ system involved, and then our emergency rooms and hospitals. And then if you need even higher level of specialty care, then you go to a tertiary care center, or if you're in the hospital and you're getting very seriously ill, you might go to the critical care unit. And then when we talk about quaternary care in medical care, what we're talking about are special centers like the University of Kentucky, where it might be a transplant center, or a place like MD Anderson or Mayo, where there's clinical trials going on for rare conditions. And quaternary care services have the highest complexity in uncommon condition care. Next slide. And so when we're talking about community-based care, so outside of a hospital, different levels depending on how physically dependent or independent they are. The first level would be ambulatory clinics. I think most of you guys work with folks there, and they can have like telehealth. And to get that care, though, for each visit, you might have a co-insurance or co-pay, unless your insurance or Medicaid pays for it 100%. And especially for elderly patients, when you need a little more social structure and less isolation, you have an option for independent living communities. And this isn't really medical care, but it's kind of a social support for that, but people have to pay for it out of pocket, but it can help them be connected a little more easily to the medical system, just because we know that there's a group of people who might have conditions because of advanced age. Then there's assisted living, which also provides social structure and also provides assistance with activities of daily living like ambulation, and maybe occasional bath, maybe just reminders of how to set up their medications for the day. And this is not covered, again, by Medicaid. And then you have skilled nursing facilities, or what we think about it as nursing homes, but that nursing homes can provide this level of care called skilled care. And you'll have skilled nursing for like wound care, or therapy or physical therapy, to learn how to walk again, or how to move and transfer in bed, medication adjustments, any medical equipment, social services. And this is paid out by a daily rate, like a per diem daily rate. Medicare Part A will cover this, but there's a limited numbers of days per benefit period per like year of Medicare coverage that they'll pay for a person. And then long-term custodial care. So that's also what we think of when we think about nursing homes, but they're not getting the skilled benefit. They're not really advancing in progressing and getting stronger. They're as good as it's going to be, so to speak. And they have a chronic condition. Recovery is not expected. And Medicaid will pay for this. Medicare does not. It's kind of what when we talk about when we'll say, how do you pay for the room and board? You may have your medications covered. You may have your doctor visits to the nursing home covered, but you don't have the room and board covered unless you have Medicaid. Next slide. And for people who decide to stay in the home and are trying not to be in a facility or nursing home, as far as medical care, there are different levels of medical home care. I found this graphic and liked it because it let you know what is the level of care type, and the level of physician involvement. And so you can have personal care services, which oftentimes could be paid out of pocket for like a sitter or someone just to help with like housework, or just helping you get adjusted in bed. And then you could have a home health care, which is covered by Medicare, and that will cover things like physical therapy, occupational therapy at home, social services at home, and intermittent home health aid, and some durable medical equipment. And then some home-based primary care services where you have a medical provider or physician coming to the home instead of you going to their clinic. Next slide. And then when we're thinking about going to the hospital, the levels of care, you usually start oftentimes in an emergency department, or you have a planned procedure. I put those at the end because they're, and then you could be then admitted to the hospital. And when you're in the hospital, there are basically 3 levels of care depending on how sick you are. So if you're on a general medical surgical unit or observation unit, or like a holding unit, you are sick enough to be in the hospital, but you're not the most sick. So they're probably doing vitals, maybe 3 times a day on a shift. But you're getting medical treatments where they're needing to change medication regimens and look at it every day. When you need more closer monitoring and you're sicker, you'll be in a place called progressive care. That could be called telemetry, that could be called step down, or it could be, after a procedure, but they're monitoring vitals on you more regularly, maybe it could be even once an hour, maybe while they're monitoring you. You have leads on your chest that are telling you how your heartbeat is and checking your connecting you to a pulse oximetry and checking what your oxygen level is every step of the way, like every second. And then when you're very sick, and there's a high risk of death, then they'll put you in critical care. Well, they'll try to stabilize you. And sometimes, and not all the time, but a lot of times, that could be things like needing to be on a ventilator for breathing support, or other kind of organ-specific machine, where you're very ill, or medications to keep your blood pressure regulated that need to be monitored like every minute, monitoring, and the nurse close to the bedside or at the unit, and lower nurse to patient ratio to take care of them. And then procedural surgical care, that could change your level of care depending how you did with the procedure or surgery. It could either stabilize you or that you're sicker for the immediate recovery. Next slide. And then when people are rehabilitating and getting physically stronger, these are the levels of care for that. So I kind of rated it independent to dependent, although home health could float in there as far as services. But when you're very strong and you can go to an outpatient physical therapy gym, it's just like a medical appointment. When you see a doctor, you might have a copay or co-insurance. If it's not covered 100% by your payer, and every visit you're seeing the physical therapist and having your appointment time where they're teaching you what you need to do to get stronger, and advising you on certain equipment that could help with that as well. And then the acute inpatient rehab stay. So this could be an acute rehab hospital where it's very intensive rehab, where someone is getting up with the physical therapist and can participate very intensely for like 3 to 4 hours. They'll take them to the particular gym of that hospital. So around here in Lexington, that would be like our Cardinal Hill Rehab Hospital. And then there is, a medical physicians overseeing that care and also looking at the medications for that. And then the next level of care would be skilled rehab, where someone probably isn't strong enough to do that very intensive physical rehabilitation. Maybe they were debilitated to start with, or they just have so much more ground to gain to participate for several hours. And so this is where, again, we think about that nursing home skilled level of care. And that's what this skilled nursing facility rehab would look like. And it would be a longer stay anticipated. So instead of like 1 or 2 weeks intensively, it might be a whole month, maybe 2 months. And there's some medical supervision required, but the physician's not like rounding every day or maybe even once a week. They're just kind of signing off on the overall plan of care. And then home health physical therapy, which is less intensive. And I put it in a slightly different green because that could float. Maybe someone just needs a little bit of support and they don't need to do the gym the whole time. And they just need a little bit of occupational therapy, for example, just to learn how to dress easier, like if they have a new limitation of an arm, for example. But usually people who can't go out to the gym or do very intensive rehab will get home health PT. Next slide. And so thinking through that, what are the barriers to that care? So there's probably less perceived barriers, but as we know, social determinants of health, lead to barriers. If you don't have a caregiver, if you don't have transportation to those services, if you can't afford the out-of-pocket, co-insurance, co-pays, or all the equipment costs, and then just healthcare literacy of knowing about what your medical providers are telling you is going on with you and what you need. And then, of course, just stigma of limitations or of age that exists in medical care as well. Next slide. And then moving on to care navigation. So first off, I covered all of those things, and I know it was all inclusive, and I know it was also a lot. If I'll just pause a little bit, if there was anything that either was new or doesn't make sense, please, put it up in the chat. And then of course we'll have the Q&A next week. All right, moving on to care navigation. So care navigation has never been more important than since the pandemic. So even for someone who is just straightforward, this is my mental health service, I've been treating for depression for a while, this is straightforward, that's all I need, or this is my medical care, straightforward for a while, are having barriers to it. So from the pandemic effect, this was the SAMHSA survey talking about the effect on mental health services and what those barriers were. So a lot of people experienced having their appointments moved from in-person to telehealth, which may or may not be a good thing for somebody, especially if they do better in person or need to have that connection with the person or would benefit from a physical examination. Over a third of people had delays or cancellations in appointments. Delays in getting prescriptions was next most common, and then just unable to access the care they needed and resulting into a moderate or severe impact on their health. Next slide. And we see that also in medical care, a significant number of people having appointments moved and delays or cancellations in appointments, delays in getting prescriptions, and unable to access care, and then their health worsening. And we're still seeing that today. This is the end of 2020, and I'll just say from personal experience, still delays. I had an appointment myself that was rescheduled because of having screened positive for COVID within the past 2 weeks, and it's being rescheduled. And so there's delays in that. And And so this effect is still there. So next slide. And so when you're working with someone, just remembering, okay, the basics of where is the hub to get treatment, what is going to be the best way to use the system to get them everything they need. So the hub really should be everyone having some kind of primary care provider and clinic. And so this would be someone in like a family medicine clinic, an internal medicine clinic, pediatrics, or for women, obstetrics, gynecology, they can serve as primary care. And so that clinic can provide some preventive screening and counseling and healthcare maintenance of the most common conditions. They could also send appropriate referrals to specialty care, but specialty care, so that would be like your cardiologist or whatnot, they focus on those specific complex conditions, and they can give general counseling, but is not like usually the hub. And then mental health care, especially for people with serious mental illness, kind of feels like their primary care because they're seeing that clinic most often. And in recognizing that, there's now an emergence of community mental health centers, of recognizing people with serious mental illness see their psychiatry specialists most often. And so we should integrate getting that medical care and primary care there. So we're going to see an emergence of certified community behavioral health centers. And I know at least here in this area, New Vista is one of those where it's traditionally a community mental health center is now trying to integrate primary care into those services. So there's no wrong door, so that you can get identification or preventative screening for medical conditions, as well as maintenance of psychiatric care. And then for specialty care, knowing that for insurance to cover it, most of the times you need a primary care office to send a referral order for the insurance plan to cover it for things like specialty evaluation and care, therapy services, home health, and DME. Next slide. And then just a brief overview of Medicare, Medicaid. So Medicare, there's Part A, which covers the cost of hospitals, skilled nursing facilities, home health, and hospice. And so when it comes to hospice, because of that's the work I do, if someone has the Medicare A covering for hospice services, they cannot at the same time be getting full coverage for like skilled nursing facility benefits or home health. And so that comes up a lot in the work that I do when someone's thinking about when do I access the Medicare A hospice benefit for my loved one who has a shortened prognosis. And then Medicare B covers all outpatient care services and home health, vaccines, preventative care, and the durable medical equipment. And then for Medicare Advantage, also called Medicare Part C, which original Medicare does not automatically cover, but this is an option for people to pay a little extra for. It bundles A, B, and Part D, which is the drug coverage plan, and that has some different options for dental, vision, and hearing coverage. And then there are Medicap policies that people can also pay into, which can help decrease cost of co-insurance or what their deductible is. But those policies, these do not cover things like long-term care or non-skilled, that long-term custodial nursing home care. And they don't usually cover things like hearing aids or eyeglasses or private duty nursing. But Medicare is, if you're over the age of 65, you'd be eligible for that. Or if you have end-stage renal disease on dialysis, you'd be eligible for Medicare to at least cover those expenses. Next slide. And then for Medicaid, knowing that this is the like Kentucky, it's called Kentucky Next, is where the website has everything for the Kentucky Medicaid. So this is a program that helps with medical costs for people with limited income. And so you have to qualify that and show that there is a limited income, or that costs of living significantly outweigh any income. And it varies from state to state. And so, if you qualify for both Medicare and Medicaid, a lot of things could be covered. To be eligible, children are eligible, low-income adults, The caretakers could also look into qualifying for Medicaid, pregnant women, elderly, and as I said, people with disabilities, and dialysis being one of those. Last slide. And then just the overview of Social Security and what that is. So when someone says, do you have SSI? That's a supplemental income that they'll send to people who are 65 and older with very limited income and assets, and it's needs-based. Again, if you have a low enough income, you can get SSI. For people who have worked and have a work history of 5 years full-time over the past 12 years, but who have a new disability that's expected to last for at least 12 months, they can also get SSDI, or Social Security Disability Insurance, as another benefit. Next slide. So I'm going to wrap it up by talking about all the different healthcare workers as you're helping your client or yourself or going through the medical system and are interacting with all these people, and to just be like, who are these people and how do they interact with them, and who's going to help me with what I need. Next slide. And so first is just an overview of what all of the different medical specialties when we're interacting healthcare. So it could either be broken down into like age or a phase of life. And so that's when we think about obstetrics for pregnant women or pregnant persons, and pediatrics, internal medicine for people who are at least 15 years of age and older, just physiologically, things have changed. Some internal medicine might cap that more in the early 20s, actually, because there's still a lot of brain and body changes in adolescence into early young adulthood. And then geriatrics for elderly patients, which traditionally we think about somewhere around 60s, but also knowing that we can have geriatric syndromes earlier, especially with people with serious mental illness or substance use. We could have geriatric syndromes of decrease in cognition and decrease in physical function earlier in life, like even in the 50s. And then at the end of life, hospice medicine, which is not necessarily age, but phase of life. If there is a diagnosed condition with this, which is expected to have in the United States, expected prognosis of 6 months or less, if the medical condition or medical conditions were to progress as they usually do. You could think about medical specialties also about the acuity or place of care, such as primary care outpatient versus in the hospital and emergency room, or critical care. And then hospitalists, if someone's in the hospital and they say, I have a hospitalist, that's like saying I have an internal medicine or family physician who's like my primary care in the hospital. They're overseeing the overall plan of care, working with all the specialists to bring this together. They're the ones that decide when I am admitted and discharged from the hospital and make sure that I have my follow-up appointments. And then you have surgical specialties and surgeons who focus on the types of surgeries they do and some of the healing care around that and deciding who needs surgery, and who work closely with the surgeons is you'll see anesthesiologists, and they'll come in because they're the ones that are monitoring you while they're providing and making sure your vitals are stable, and sometimes providing mechanical ventilation, depending if you're just sedated or if you're under anesthesia. So there's the anesthesiologist, doctor, and their team in the room during the procedure, taking care of you and immediately afterwards. And then we have specialties that we probably won't see the actual physician or provider working on those teams, and they're behind the scenes, but they're helping with the diagnosis. So you have radiologists who read all the scans and tell the other doctors what they see there and what might be wrong with that they could fix. Then you have pathologists who look at like the biopsy results, for example, and tell them what that tissue sample was. If it looks like a certain type of infection, or if it looks like a type of cancer or a vascular condition. And then there's toxicologists who can report on like urine drug screens and what do those really mean, as an example, and geneticists who also look at the blood work and can tell if there's a rare condition there. And then on the table at the bottom is kind of how I broke up different specialties based on kind of our organ systems. And so in these, there's usually a medical type doctor who thinks about the diagnosis, the conditions, and medical treatments and medications. And then there's going to probably be a surgical counterpart who can think about what kind of surgeries they need to do to fix anatomical changes or abnormalities. So if our brain, we think about neurology, and then there's a neurosurgeon. And then, head and neck, there's ear, nose, and throat. And those, they also provide surgery as well as ophthalmologist surgery to the eyes. Pulmonary doctors who are involved with your respiratory system, but then you'll have like a thoracic surgeon, and cardiologists or cardiothoracic surgeon. And since it's an entire cardiovascular system, we'll have vascular surgeons who help with that. And so just going on to that, and the GI liver, physicians, and then you'll have a general surgeon who is the one that actually opens the belly and performs surgery. And then for kidney doctors, the ones who manage and oversee the dialysis, but then you'll work with a vascular surgeon who actually puts in the dialysis access, but it's the kidney doctor that is ordering the dialysis and the medications and that procedure. And then gynecology for women, and then they can perform gynecologic surgeries and pap smears and those things. And urologists, we usually think of that for men, but there's also gyneurology for women, and bladder dysfunction, and prostate health and testicular health for men. And then when you think about skin, there's dermatology, which are more medically trained, and they can do like outpatient in clinic procedures of like small removal of moles. But if it gets really extensive, then you think about a plastic surgeon. If you need like a flap or if there's a large amount of skin that needs to be replaced. And then for bones and joints, orthopedic surgeons, but then you have sports medicine physicians who are more about the function of the joints and the ligaments and the muscles. And the orthopedic surgeons are more about the procedures that they can do to realign the bones. And then in the gray, I put those in the gray because those are more like groups of conditions with symptoms and illnesses and less anatomical. And so in there would be like rheumatology, endocrinology, like diabetes, thyroid disease, infectious disease, for like endocarditis treatment, sepsis, and picking out the antibiotics. If you have a fungal infection, if you have a bacterial infection, if you have a viral infection, that they can use their expertise in. And then, allergy and immunology. So if someone has an allergic reaction to something, and then oncology for cancer treatment. And that's a whole team, also including radiation oncology for treatment, and then surgical oncology, but that's about cancer specific. And then psychiatry / addiction for mental health and substance use treatment. And then when we think about pain, there's many options there. And this is my world, but thinking about, different training of pain specialists, physical medicine and rehab specialists, and palliative specialists. And that is very difficult to navigate even within those subspecialties. And so just recognizing that it is complicated. And so it can lead to a lot of frustration, and validating that this is very complicated, even within these subspecialties. Next slide. And other people that you'll encounter, not only the physicians and what the medical teams do in general, are just all the people through this stay. So, and I should have, medical assistants, sometimes medical assistants are different from patient care coordinators and schedulers, and sometimes they're the same. But the first people you'll meet are like medical assistants who can just help with get information, get some vitals. And they have a different level of training from like care technicians. And phlebotomists are the ones that draw blood from you. And then there's lab techs that run those samples through the lab, and radiology. These are all technicians, but we will see them, and they all, and you're in the hospital, everyone's wearing scrubs, but everyone has different levels of training that they do to provide care for you. But all of those interactions are also very important. But these are all the people that you could see, and they have, you know, a few years of training specifically to what they do and to help the healthcare system move forward. Next slide. And then we have people who are medical therapists. So they have more specific training and longer training in physical therapy, like it's its own college of physical therapy in school, but physical therapy, which help with like gross motor, walking, regaining that function. Occupational therapists who help more with more fine motor function and activities of daily living. So if it's like your fine motor to grasp utensils again, or it could even be for like balance. Whereas physical therapy is like your large muscles getting stronger. And then speech and language pathology, like if someone had a stroke and they're trying to use their tongue again to learn how to swallow safely. But it could also be somebody who just has word finding difficulty after, say, like anoxic brain injury. For example, when I think in this context, you know, it could be someone who had an anoxic brain injury after an overdose that took long, or had a small stroke, and they need help getting those functions back. They can go to a speech and language pathologist. And then there's respiratory therapists to help with breathing and breathing equipment, oxygen and CPAP masks, for example, for sleep apnea. And then next slide. And then counselor therapists. These are also can be called clinicians in your treatment team. So understanding that social workers, there's different levels of social work. So a social worker could be focusing on case management and assessments of helping to allocate resources. But if you have an LCSW, they can actually provide mental health therapy. They've gotten more training to provide counseling. And then counselors can also be licensed marriage and family therapists. You'll see that as their degree, or licensed professional counselors. And they can help not only with mental health counseling, but also with like vocational rehab counseling, getting someone back employment. Next slide. And then all the different levels of nursing. So there's certified nurse assistants who help people get dressed and bathed and their bed made for the day, but they're really hands-on in helping the person. And then you have the RNs or LPNs who help deliver the plan of care as far as medications and administering those, and even providing some limited like wound care. And then you can have even more certified wound care specialist RNs. And then when we talk about a medical provider who has prescriptive authority and actually acts like an independent practitioner, is the advanced practice registered nurse, or what we call a nurse practitioner. Also in anesthesia, CRNAs are like nurse practitioners in the OR with the anesthesiologists, and then midwives and clinical nurse specialists also have that same degree. They're independent practitioners. Next slide. And then I wanted to break down an appreciation of all the people that we call doctor. Does not mean that all of these people are physicians, but they all are independent practitioners. And I highlighted the ones that are physicians or providers who have prescriptive authority, who can actually write medications that go to the pharmacy and get filled. So if you see a physician or someone with the letters MD, DO, or MBBS, means that they had training in another country as physicians, that they are physicians in the traditional sense. Dentists also have medical training, and so they have DMD. And so, as we know, dentists perform some procedures, and they can prescribe like antibiotics, or if they need to prescribe pain medication for their procedure that they know is going to be very painful. And then a pharmacist, although they advise about medications, and they know way more, obviously, because that's their pharmacist, about pharmacology, and support that. They don't have prescriptive authority where they come up with a plan of care and as far as medications, and then deliver that. You still need the signature of a physician on that plan of care, at least in the state of Kentucky. Psychologists are also doctors. They have PhDs or a PsyD. And so they are doctors, but they're very highly trained in mental health and in counseling, but they do not write prescriptions. And then, of course, like research PhDs, chiropractors have their own school for which they receive a doctorate degree, but they're more for manipulation and not prescriptive authority. Next slide. And when you're in a training hospital like the University of Kentucky, also realizing that you may have a whole group of, they'll say we're all the orthopedics doctors and we're all doctors, but we have different levels of training. So an attending physician is somebody who's finished all of their training. They have their own license, they have prescriptive authority, and they are not under supervision of anyone else. So they are the ones ultimately responsible for everyone that they're training underneath them. A fellow, like what I'm completing here in 2 weeks, is a person who does have a full medical license, has completed their residency, could be board certified in their specialty, but they're looking at subspecialty training. And so they do still have some supervision by an attending, but they're otherwise fully fledged licensed physician, and they might have board certification, but they're looking for subspecialty training. A resident physician is a person who has completed medical school, so they have the license of a physician, but they're completing further like hands-on medical care so that they can be eligible to sit for a board certification in their specialty. So like in the hospital medicine team, you'll have maybe a group of maybe like internal medicine and family physician residents who, after completing residency, can sit for boards to be like a board certified primary care physician on their own as an attending physician. And then an intern is a first year resident. That means they are they're just starting that training. They had completed medical school, so they do have an MD. They do have a license number, but they cannot practice on their own, similar to a resident, and they're like the newest resident. And then you have medical students who really shouldn't be calling themselves a doctor, although we might because they're going to be, but they have to actually complete their training in the College of Medicine to receive an MD to be called a doctor. So you might hear the phrase, "This is the student doctor" on the team, or they might call them doctor, but they're actually not finished yet, so they couldn't go out and find work as a physician. Next slide. And we're wrapping up. I know it's a lot. So just when we're thinking about all of this and we're trying to help advocate for our clients and the people we're working with, when we're thinking about people who might be going to the hospital, of knowing, helping them know who are the people that they need to talk to and get a plan of care for. So again, the primary team in a hospital is probably going to be a hospital medicine physician or a hospitalist. And that's that primary care doctor focused on inpatient care. So primary care in the inpatient setting. They're the ones that do the admission orders, oversee plan of care, and ultimately decide on the discharge date and the discharge plan. If you're in the critical care unit or the ICU, you might have what we call an intensivist. It just means they have special training in critical care, very acutely ill people, or it might be the surgical team if that's why they ended up in the ICU, being the primary physician in charge of their care. And so you'll get a lot of input of the cardiologist said this, the ID doctor said that. Overall, of when am I being discharged, those teams will inform that, but the ultimate responsibility goes to the hospitalist or intensivist. And then, as far as consultants, every hospital has to have a base of specialists that are available, like a surgeon maybe, but they don't have to have all of the levels of like cardiothoracic surgeon who can perform certain procedures or whatnot. So that's why you'll hear about people being transferred to a different hospital for what they'll say is a higher level of care. So again, talking about that quaternary care, where you have highly complex specialists and subspecialists available to them. But one note, when we say specialists, including psychiatry, it is not mandated really that anyone has to have a psychiatrist on site. They can have maybe psychiatry be available to talk to the other doctors, but that would be when you're in a psychiatric hospital where you're going to have a psychiatrist on site seeing them. Palliative care is not in every hospital, but it is an option for people who are seriously ill to help support the care teams, as well as support the family members when there are many specialists involved to help distill that down and really talk about what the options are and what the symptoms maybe aren't being managed, and to help advocate and help in that role. And addiction medicine teams are not in every hospital as well, but they also provide that role for people who have substance use and substance use disorder, of really distilling things down and talking about what is their plan of care and what do they need to do to get through withdrawal and those symptoms. And then pain teams also, they're hospital dependent as well. They're not automatically going to be everywhere. So that would be subspecialists who are familiar with complex pain management. So just being aware of that these specialists are very hospital dependent and aren't going to be in every hospital that you go into. And then just as far as advocating, everyone in the hospital will have a bedside nurse or floor nurse, and they can tell what the overall plan of care is and could be a good first person to ask about what's going on here if you have the permission to receive that information. And then if things don't seem to be going well, that there is always a nurse unit manager to speak to that can address things just like you would when you're in a restaurant. You say, I need to speak to the manager. There's a nurse unit manager. And then, of course, every hospital should have a patient representative. Next slide. So just to wrap it up, we reviewed the levels and settings of care for medical, mental health care, and that there's a continuum of care provided. We covered that there could be inequities in benefits and coverage that negatively impact people with mental illness and substance use disorder. And that the concept of integrating medical and mental health care, as well as care navigation, can decrease the barriers that exist. And those are starting to emerge. And that, again, identifying that there are many healthcare workers who interact with people with substance use disorders. And so there are many avenues to advocate for quality of care. And that, I think that's the last slide. So I'm really looking forward. I know working with the Healing Transitions, this is what you do. You are care navigators, and those at Voices of Hope, working with people in the community setting and peer support, and then just, hearing the stories and when people interact with these different systems. I'm really eager to hear the Q&A and have the discussion next week.
Yes, thank you so much, Dr. Nichols. Especially for our, like Dr. Nichols said, especially for our care navigators and for our partners at Voices of Hope. If you have specific cases or if you have specific questions, I think this is a really good opportunity to talk about the different avenues in which, care plans can go, and answer questions about the different branching paths. So I would love it if you would send me specific case scenarios or patient scenarios, even if you think they're resolved, or if they, went extremely well, or if they didn't go well. It's really good to kind of look at those and to understand the different decisions that people make and the different healthcare professionals that are working there. You can also just send general questions based on today's content, but I'm going to go quickly through our end announcements, and then next week we'll dive into those questions and patient scenarios.